So I would love to introduce now Natalia Kelly. Natalia is a low vision orthoptist, and it's very appropriate that we have her here today because it is at National Orthoptics Week. She works in her private practice in Melbourne called Vision Matters, and she's also a lecturer in orthoptics at the La Trobe University. And I welcome Natalia.
Hello everyone, sorry, I think I muted myself. Thank you for being here today, and thank you to Macular Disease Foundation for inviting me to talk about techniques to optimise central vision loss. Before I start to talk about strategies to help with central vision loss, I thought it would be a good idea to cover what central vision actually is. The image on your slide now shows a healthy retina. The retina is a nerve layer that lines the inside of the eye and is involved in the first stages of vision. The macula is an area on the retina enclosed in the blue circle, and it's responsible for central vision. Damage to this area consequently causes central vision loss. So we can see from the image on the right, the macula inside the blue circle is affected by an eye disorder, and this one in particular is called Stargardt's disease, which is a form of macular dystrophy. Central vision plays an important role in our ability to drive, read, recognise faces and perform general daily activities. Therefore, it's no surprise that people who have an eye condition that impacts the macula has greater loss of independence and report reduced quality of life than other forms of vision loss. The premise of low vision practice is to optimise residual vision in order to improve quality of life. Low vision rehabilitation for those with macular dysfunction is commonly addressed by introducing magnification using optical or electronic magnifiers, so what you would call a video magnifier. The use of optical character recognition or speech software is also gaining popularity. Education and lighting and enhanced contrast function also play an important role in optimising vision. Whilst these interventions hold merit, the use of eccentric viewing is commonly overlooked and also underutilised. So my hope today is to provide those with central vision loss with an understanding of an alternative and effective option in optimising vision. Many doctors and professionals are unaware of what eccentric viewing actually is and therefore do not refer people to seek services. They are also very busy in their clinic, and referral to low vision services can be overlooked unconsciously. Eccentric viewing is a possibility that can make all the difference to people with central vision loss and give them an opportunity to improve their quality of life outside of medical intervention. So I hope the information gained from this talk will help you advocate for yourself or your loved one and ask to be referred to an orthoptist working in low vision so they can help you use your vision better. So I've mentioned eccentric viewing, but I will talk further about what it actually is, some key principles around this, the techniques used for training eccentric viewing, who's eligible, and what are the outcomes and benefits of eccentric viewing training. Eccentric viewing training is a technique used by people that have central vision loss in both eyes. What happens is that the person tries to compensate for their vision loss by attempting to look around the area that is lost. The technical term for eccentric means not placed centrally. So with eccentric viewing, the person looks off centre or past the object in order to see it with their peripheral vision. This means that instead of the image falling on the centre part of the retina, where the damage is, they move their eyes off centre so their image falls on a peripheral or side retinal area that is not damaged by this disease. Many people with central vision loss eccentrically view either consciously or unconsciously. However, research has found that those that intuitively eccentrically view often use more than one point on the retina. Researchers also found that people who self-train frequently move their eyes around to locate the best area to use. This is called inconsistent fixation. Fixation is your ability to hold your eyes steady so you're able to see or focus on something. Eccentric viewing training is founded on sound scientific evidence dating back to the 1970s. The literature has shown that when there is a structured approach in assessing the central vision loss and a clinical consideration is used to identify the most appropriate retinal area for looking, then there is a better chance of success and impact on improving quality of life. The graph on your slide here is data that's been extracted from a study by Vukasevic and Fitzmaurice. This study compared people with age-related macular degeneration. One group received training while the other continued to intuitively eccentrically view. The results showed that participants who had eccentric viewing had an improvement in their near vision results, whereas those who didn't have training had no change in their vision. These results appeared to be consistent with other studies. This particular study by Vukasevic and Fitzmaurice also went on to show that participants with training also improved in everyday activities such as reading, writing, meal preparation. Eligibility for eccentric viewing needs to be established first, and this is done through a series of tests, but it's important to mention that none of these tests are invasive. People who would benefit most from eccentric viewing are those with central vision loss in both eyes. The training requires you to be able to understand and follow instructions. Therefore, those that are older than 7 years would be considered a good candidate. The training also requires a commitment of 8 to 12 sessions, whereby you will be allocated homework to establish this new way of looking. Causes of central vision loss may be due to many conditions, and this slide here shows an extensive list of the main pathologies that cause central vision loss. So people with age-related macular degeneration, both dry and wet, Stargardt's disease, which is often found in younger people and children, retinitis pigmentosa, cone dystrophy, diabetic retinopathy, myopic macular degeneration, Leber's optic atrophy, retinal vascular occlusion, and ischemic optic neuropathy, end-stage glaucoma, and also field loss associated with multiple sclerosis. Although this is an extensive list, it's important to note that there are many more conditions that cause macular damage that aren't listed here. In my experience, those with age-related macular degeneration commonly inquire about eccentric viewing, but I feel this is predominantly due to the lack of awareness of how this training can benefit other conditions. Recently, I've had the privilege of being able to see patients with Stargardt's disease, non-specific macular degeneration, end-stage glaucoma, and also retinitis pigmentosa. All have been benefiting from the training. A point that I'd also like to make is that eccentric viewing or low vision rehabilitation in general complements and does not replace medical treatment that you will receive from your ophthalmologist. Some of my patients who are on the eccentric viewing program are also receiving eye injections or other medical treatment and surgical management from their ophthalmologist. So this is something that we do with the ophthalmologist. So you may be asking, when's the right time to think about eccentric viewing training? And my answer would be as soon as there's evidence of macular damage in both eyes. When you go to your ophthalmologist, they take photos at the back of your eye. If the doctor tells you that the macula in each eye is damaged, then this is a good time for you to talk to him or her about referring to a low vision orthoptist. Many professionals use eye charts as a guide to refer low vision services. However, research has shown that this test is not necessarily the most accurate indicator in identifying when someone is having difficulties with everyday activities and therefore referring to low vision services. I've noticed that when there is evidence of macular loss, then my patient's eyes actually start to move and search for better vision. You may notice that if you've got central vision loss, that when you're reading the letter chart at your ophthalmologist or optometrist, that your eyes might, or that your head might be moving around to be able to see the letters a little bit clearly, or when you're reading, the words are jumping around. So this is an indication that your fixation or your ability to focus is unstable. Fixation stability plays an important role in maintaining clarity of vision. When the eyes are unstable, there is an artificial blur of vision because the eyes are moving around, and this movement is usually constant and also unconsciously happening as well. So early intervention is the key to optimizing vision, and in my experience as well, I've noticed that those that come to see me earlier actually respond better to adapting to the training faster. When you first see a low vision orthoptist, as I mentioned before, they'll do a series of different tests on you. And this is to be able to get an understanding of the vision loss you have and how you're using your vision. For one of the tests they're likely to do is a visual field test, and the results of a visual field test is what you can see on the left of this slide. This test maps out your central field loss and gives them information about where your field loss is and what part of the retina is most viable to be used for training. If you're unable to do a visual field test because your central vision loss is too great, or you're having difficulties performing the test for other reasons, then there are alternative options that the orthoptist can use to locate the best area for you. They can use something that we call the smiley face grid that you can see on the right side of this slide. This tool was validated as an effective instrument in locating the most suitable location to be trained for eccentric viewing. In my clinic, I use advanced visual field testing to evaluate the central vision loss. This machine is called the Macular Assessment Integrity Unit, or the MAIA. And this machine is relatively novel to Australia, and currently I'm the only person in Australia using the MAIA for low vision rehabilitation. The MAIA enables me to see the extent of retinal damage and provides specific information about how sensitive the retina is at different locations. Additionally, the MAIA also provides information about how steady the eyes are, or the fixation is. As you can see on this slide, the image on the left is a typical retina, and the image on the right shows a retina that's been affected by age-related macular degeneration. So the area that you can see that is in white, this is the damage of the macular degeneration to the retina. The MAIA colour coordinates, the MAIA colour coordinates how healthy or sensitive the retina is. So the green areas indicate good retinal sensitivity, and the warmer the colours are, it indicates poorer retinal sensitivity, and the black areas indicate where the retina is no longer working. The aquamarine dots also reveal how stable the eyes are, and as you can see, the dots are clustered together in a typical healthy eye, and this is encircled with the yellow circle. This shows you that fixation is stable. When the image of whereas the image of the retina with the macular degeneration, the dots are more spread out and the eyes are moving around a lot to try and focus, and this represents unstable fixation. To be able to obtain, so the MAIA gives me a significant amount of information that allows me to confidently choose the right retinal location that's specifically tailored to that patient to optimize their vision. So eccentric viewing involves teaching a person to move their eyes to a specific position away from the center so the image falls on the retina that is being chosen to be trained. So this is a new way of looking that will replace you looking straight ahead. The literature has shown that 8 to 12 sessions are needed to be able to make a change and produce better vision. In my practice, patients generally see me weekly for the first half of the program and then fortnightly for the remainder of the program. Patients will be provided with training material and tasks for them to practice in between sessions. This homework is actually an essential component for the success of the program. And I found that patients that don't do the training really struggle in establishing this new eye gaze position within the time frame of the program. There are different types of training methods to teach eccentric viewing. Traditionally, and this is most commonly what's found in Australia, is reading materials are used to teach you how to move your eyes to a specific location to be able to see. You're likely going to be designated reading homework and other tasks that should revolve around your goals to improve activities of daily living, such as being able to recognise faces, watch television, or see your food when eating a meal. In my clinic, I employ biofeedback eccentric viewing training. This method is relatively new with research dating back to the early 2000s. It's considered a neuromotor rehabilitation method because the technology encourages the eyes and the brain to work together to access a precise training area on the retina. Biofeedback eccentric viewing is conducted through the MAYA. This training directs neuroplasticity by combining sound and light to help patients move their eyes to an exact position at every session. By working this way, this method also addresses fixation stability. Excuse me. This is a progress map of one of my patients who has non-specific macular dystrophy. So the area that you can see that is white is the area that's being affected by the macular dystrophy. The first image on the left shows you the visual field results, and you can see the little coloured dots here, and it also shows you the eye movement scatter of this patient, which is the aquamarine dots. And this patient is trying to search for better vision, but they're actually searching within the area of field loss, and that's what this is showing here. So what you can see through this progress map is that at the start of training, the fixation becomes more directed, and as we progress, the area or the fixation area becomes more and more condensed and stabilized. And what you can also see is that at each session, the point that's being used or chosen is the exact point, and it's highly reproducible as well. So ideally, eccentric viewing should be offered in person. The initial assessment should, if possible, be conducted in a clinic or so eligibility of the training can be accurately and comprehensively assessed. However, the circumstances of COVID-19 has highlighted to me that eccentric viewing training can be creatively adapted for telehealth for those who are unable to attend clinic regularly or at all. The use of telehealth has enabled the expansion of this treatment so it can be more accessible to people. Some people who would benefit from this training but may be deterred by having to attend clinic regularly may not think that this is a realistic option for them, either because of their health or their dependency on transport, or just because they just live too far away. So telehealth can be a useful tool to reach more people. This said, there is a criteria for telehealth that should be considered and discussed with your orthoptist. So it's best for you to have a conversation with your low vision orthoptist about what options are available for you and what form of service delivery will help you gain the most out of this training. So what are the benefits of eccentric viewing? I think it's important to say that eccentric viewing is not a miracle cure that will enable you to regain perfect vision. Unfortunately, perfect vision is unattainable because the macula has been damaged. What eccentric viewing offers is a less blurred image that helps you use the remaining vision to its optimum potential. The training provides guidance to help you use your vision better than what is currently being achieved. When I speak to my patients about what they find beneficial from doing the training, a lot of them report reduced symptoms of anxiety and depression, and also the reduced risk of them being socially isolated. Many of my patients prior to training reported that they were actually considering giving up social activities such as playing bridge. Eccentric viewing gave them confidence and the ability to continue to regularly attend games, which has been important for them to continue to feel connected. Some patients also reported increased confidence to return to voluntary work, whilst others began new hobbies and such as woodwork, painting, and also leatherwork. Whilst anecdotal stories are helpful to gain an understanding of the scope of eccentric viewing benefits, it's important to make note of what the research has found. So there's been an extensive amount of studies on eccentric viewing training, and there's also been systematic reviews that have evaluated the effectiveness of the training. There is consensus in the literature that eccentric viewing training clinically improves distance and near vision, contrast sensitivity, and fixation stability. Functionally, studies have shown an improvement in reading ability, both in the speed and accuracy of reading and performance of daily living, such as writing, personal care, meal preparation, and eating as well. As part of my master's research, I conducted a pilot study where I analysed outcomes of 17 of my patients that completed the biofeedback program last year. The results showed that there was an improvement in all of my patients and across all the clinical measures. So on average, there was an improvement of about 2 lines or 12 metres in their distance visual acuity. Near visual acuity also saw a functional improvement to around about 10 font. Most were able to read 12 to 16 font comfortably. And this is functionally significant because this is the size of standard print to large print font that we see in documents, and this is without the use of a magnifier. Contrast sensitivity also improved 33%, but the greatest improvement was seen in the fixation stability. So on average, people improved their fixation by about, there was an improvement of about 65%, but yeah, we're looking on average at 90% success rate. So 90% of the time, they were successfully able to refixate to that point and also hold that fixation at that location. So I thought you might also be interested in seeing the results of one of my patients who's currently undergoing eccentric viewing training using the biofeedback. We're halfway through his program, and I wanted to, I chose this particular patient because he has a condition known as retinitis pigmentosa, which has left him with a very small island of vision just off the centre or the macular area. So as you can see here, the area around this dark bit is the retinitis pigmentosa, and that's affected the macular area. So with this patient, prior to commencement of the training, you can see the aquamarine dots have been really quite scattered, and he doesn't really have, he's not really using his vision very optimally. And you can also see with the graph below, his eye movements are also quite greyed and also quite inconsistent. At the start, his measures, so his detail vision was about hand movements at 50 centimetres, and what that meant is he could only see my hand moving. And at best, he was able to get 22% of fixation stability success. So halfway through the program, and I gathered these results a couple of weeks ago, we were able to really kind of hone in on that area that would be useful for him. And you can see here as well, his the amplitude or his eye movements have also quite settled down quite a lot and are quite stable as well. His visual acuity improved from hand movements to 672, and this is partly also because the retinal area that we're using is also fairly reduced. But his fixation stability has improved on average to around about 94%, and sometimes he's actually hitting 99 to 100% as well. So this is just showing you that how eccentric viewing can also help people that have quite advanced levels of vision impairment. So when it comes to low vision services, magnification remains a primary option to help people with reduced central vision. Whilst this is a viable aid, its benefits are limited to reading activities. Additionally, the strength of magnification is dependent on your level of vision. The more reduced your central vision is, the higher the magnification power that's required. And if you're using an optical magnifier, the lower or the smaller the field of view that you're able to access for you to be able to read your bills in the newspaper. Eccentric viewing can be offered as a complementary intervention option in addition to using the magnification device. So eccentric viewing training can help improve your near vision, resulting in the need for a lower powered magnification, which will give you greater visual field of view. And all of this assists in improving reading ability. So if your vision is significantly reduced and you're using a high-powered magnifier, then consider employing eccentric viewing to help you. The scope of eccentric viewing training can help many people who have central vision loss. I have a strong conviction for this training because I've seen multiple times over the profound difference that this has made on the mental health, the self-confidence, and the restoration of independence in my patients. The training has eased anxieties faced by many of my patients and has given them hope for the future. I hope that this presentation has brought to the forefront the importance of this training and that this training is an option to make the most out of your central vision loss. For more information about eccentric viewing, or if you feel that I can help you, feel free to contact me. My details are on the screen. I would also direct you to my website, which is www.visionmatters.com.au, and this has some more information about eccentric viewing and also lists my details as well. Thank you again for your time, and also to Macular Disease Foundation for giving me this opportunity. I will now pass you back to Sabine, who will talk to you about Macular Disease Foundation. Thank you.
Thank you so much, Natalia. That was a fantastic presentation. That's an area of orthoptics that a lot of optometrists don't even know about. So it's really worthwhile having you come in today. Thank you. So I will just remind you that, of course, if you would like to ask Natalia some questions, we just need you to go to the question box. So go back to that panel on the side, and if you click on it, you can go down and ask a question. Before we go to the questions, firstly, I would like to just talk about the Macular Disease Foundation. Of course, you know, we were established in 2001, and our emphasis is to reduce the incidence and impact of macular disease. We do that through various pillars of work, the first of which is education. We host education sessions all around Australia, last year to nearly 7,000 people. And at these education sessions, we talk about what AMD is and also other macular disease, diabetic eye disease. We talk about risk factors, what you can do to modify your risk factors and maybe improve your outcomes, and also about a little bit about the services that the foundation can put you into touch with. Of course, during COVID, we've had to pivot like a lot of other organisations, and so now we've been doing these webinars, and that's been fantastic. We've been able to really increase the number of people that we're reaching, and particularly people who are rural and remote. Awareness, of course, is important. The foundation was established back in 2001 because at that time, AMD wasn't very well known. There was definitely a lot less known about risk factors and what people could do to modify their risks. And so the foundation really developed initiatives to make sure that all Australians know whether or not they're at risk. One of those initiatives is our Macular Month, which we've just passed. And in Macular Month, you'll see a lot of information about the macula and about macular disease in all sorts of media. This Macular Month was slightly different again because of COVID-19, and we were reaching out to the macular disease community to make sure that they kept up with their normal treatments and appointments. So it took a little bit of a different slant. Client services is, of course, the very centre of what we do. I will be talking a bit more about that next. Advocacy. So a lot of this type of work happens behind closed doors, and The initiatives often involve trying to ensure that people can access care without the costs increasing, particularly the out-of-pocket expenses that may be incurred when you go to the doctor. And other initiatives are in process of trying to improve treatment access in the public system. Our research grants program since 2011 has granted $4.2 million in funds to researchers who are all looking at this field and really trying to find the cause of AMD and perhaps some treatment options. And of course, last but definitely not least is the people who help to fund us, our community. We thank you for your generosity and we really appreciate your support. So we were talking a little bit about what the foundation does. The most important part of our work is our national helpline, the 1-800 number. We field hundreds of thousands, well, not hundreds of thousands, but lots of calls every year. And the questions that we answer can range from across different topics. So it might be about the disease, it might be about accessing treatment. We often get questions about Medicare, about the aged care and the NDIS as well. In addition to that, we of course have a lot of resources outlining disease and about the modifications that you can make to your diet and lifestyle to improve your outcomes. And these resources are available in 7 different languages and also in audio version. And you can access those through our website. When you go to www.mdfoundation.com.au, you go to resources and you can order anything there and it's sent out to you at no cost. So I'm now going to bring Natalia back and we are going to go through some of the questions today. So we have a lot of questions. Thank you so much to everyone who has contributed these questions. I am going to sort of go through the list and pick out the most common themes and we'll go from there. Are you all set, Natalia?
Oh, we'll see. I'm bracing myself.
Brace yourself. So the first question is, how long is your program? Does it vary from person to person depending on their ability to eccentric fixate? And how diligent are they with their homework? And how long do you find patients need to attend in the initial part of the program? That's a multi-parted question, that one.
That's a multi-parted question. So yes, so some patients, so there's a guide of so based on the literature, so my practice is based on evidence-based practice. So based on the literature, they're saying between 8 to 12 sessions is ideally required, but each person is actually quite individualized. So some will take to the training really quickly and will be able to finish the program between 3 to 4 sessions, but then I would want to I'd want to follow them up to make sure that we've established this new looking behavior long term, so the eccentric viewing long term. Others commonly sit around about that 8 to 12 session mark, and then some others will extend it a little bit longer as well. And there is a follow-up part outside of the intensive 8 to 12 sessions as well, because currently there hasn't been any longitudinal studies, and this is something that I'm going to be looking into with my high degree research, but at the moment there hasn't been any longitudinal studies, and we are talking about neuroplasticity, which is changing the brain, and we need to make sure that and we're also changing behaviours and belief systems, so it takes a little bit longer than 12 sessions. So there are follow-up sessions, but not weekly at all by any means, or monthly by any means. Now, the homework is an essential component to it. So those that do their homework diligently, so daily, they're the ones that actually respond much better to the training. Because what they're doing is that they're really cementing these neural pathways and these behaviours. Those that don't necessarily do the training, they take a little bit longer. And how long the training goes for is really dependent on my patient. So this is a collaborative effort. And so even choosing the retinal area to use is it's all very collaborative approach. Now, I think I've forgotten the rest of the...
I think you answered most of that, actually. There is a little adjunct question which is related. So is it ever too late to refer? You were talking about neuroplasticity. Is there a point sometimes where you shouldn't?
Yeah, no. I would say, so I work with patients with very reduced vision loss. So if there's and my retinitis pigmentosa patient is an example of that. So he has a very small island of vision. So not necessarily. I think the only challenge would be cognition. So if someone is unable to remember what to do, that's where we have a bit of a challenge. But that said, I'm also seeing older participants or older patients that have mild cognitive impairment, and they've got some great family support to reinforce the training, and they've actually been doing really well with the training. So no, the long answer to that is no. It's not too late.
Now, you may have already answered this question, but I thought I'll ask you just in case. How long does a session go for? So when they come and visit you, how long does that session last for each time?
Okay, so the initial assessment with all the intensive testing, that goes for 75 minutes, and then subsequent appointments are 45 minutes. But that's my method. So depending on the orthoptist that you choose to go and see, they might take a different approach to how they want to do their subsequent appointments.
And another question, are the costs covered by Medicare?
Unfortunately, orthoptics is not covered by Medicare, but we are covered by NDIS. You can claim also through your My Aged Care plan. We are covered through private health insurance as well, and DVA, Department of Veterans Affairs. If you're a gold card holder, that will cover the full cost and transport to and from the clinic as well.
Do you have any tips for techniques to use at home?
So this would be part of the training. So and this should be incorporated. So what the aim of this eccentric viewing is to extend it beyond reading, but for you to pretty much replace a new way of looking. So so it's a little bit hard to say the tricks because I don't know specifically what retinal area is working, but that's exactly what I do with my patients. Is their homework comprises of not just reading but everyday activity tasks as well.
Yeah. I know in my practice that I have a patient with macular disease who likes to sit side on to the television. That's the way he can see the television better when he's looking from the side. He's kind of worked that one out for himself.
Yeah. Look, some people, like I said, some people intuitively find this, but I guess the thing about eccentric viewing is actually you're moving your eyes, not your head, and that's the best way to actually shift the way the image falls on the retina. I hope I'm not being too technical, but I hope that that makes sense.
Another question is, can I access this training at my local low vision service?
I'm not sure. So orthoptists are trained in eccentric viewing training and being able to implement the program. So you will need to talk to the orthoptist, and they're their specialty, they're the discipline that you'd be talking to. So I know that that's definitely in the curriculum and they get assessed on that. So yes, so I would be talking to your low vision clinic.
Another question, you mentioned that you can be referred to a low vision orthoptist when there's macular damage to both eyes. Can I be referred if I only have damage to one eye?
Yes, yes, you can, and you should be as well.
Okay. This is also related to another question we had. I've had poor central vision for a long time. Does this mean I won't benefit from training? I think we've answered that one, haven't we?
Oh, look, can I just to let you know, I have a 96-year-old woman on my books, and she's doing really well, and she's also got quite extensive macular degeneration, and I've got a few of my patients that are 90 plus. So I would say no. If you've got the motivation and to do it, then you'd be a great candidate.
That's great. Now, I had another couple of questions that were sent in ahead of time. This is slightly different, sort of slightly off topic, but still interesting, I think. I have read that UV light increases deterioration. How can I improve lighting in a room without increasing UV exposure? That's a curly one for you, Natalia.
That is a curly one for me. So they're talking more about the UV light that's coming from outside, from the sun. The literature on that is a little bit inconsistent, I would say. But what you would be looking at indoors is actually glare, and making sure that you control glare within the house. And so if you've got quite a glary room, whether or not the glare is coming from the actual light source of the globe or from a window or whatever, but I think with this particular person, they're talking about a globe. You want to get what we call a diffuser, like a light diffuser or a cover, and that would help with that.
That's fantastic. Look, I think that's all the time we have